Post-sedation recovery. Recovery after sedation is quite often something that we neglect, it was just sedation. And I'll show you why that approach is so wrong. Now, this all started in 1970 with the publication by Antonio Aldretti and Diane Krulik on a post-anesthetic recovery score. It was, by the way, it was quite a struggle to get hold of this article because this was published in 1970 in Anesthesia Analgesia. Aldretti qualified in 1960 from the University of Mexico, Mexico City. Then he was a registrar in Colorado, and then from throughout the the United States. They published on 352 patients where they proposed for a specific post-anesthetic scoring system. They did it for all types of anesthetics and anesthesia, and they hourly noted the sex, the age, the ASA status, and observations in recovery. And they proposed, right at the bottom there, you'll see a score of scoring out of 10, where 8 to 9 were acceptable for discharge to the ward, and then a score below 8 needed longer recovery care or discharge to a high care unit. So basically, they proposed 2 points each for activity, and if a patient could move all 4 limbs, that was 2 patients that had spinals, only got 1, so that is why 9 out of 10 in the patient that's had a spinal or an epidural is the perfect count. They had to be able to breathe deeply and cough. Systolic blood pressure needed to be 20% of the pre-op value. They had to be able to answer questions to get 2 points as far as consciousness is concerned, and they used color because remember 1970 was the days before an oximeter. So pink was the color to go for, blue was the color calling for action. By the way, what I found there, in their words, they actually defined the ideal sedative drug for us. And they said it should be a drug devoid of toxicity, with immediate onset, with rapid elimination after discontinuation, provide muscle relaxation, provide post-operative analgesia without causing respiratory depression and without causing cardiovascular depression or other vital functions. Remember, this was published in 1970, so this was most probably, they took this for publication late 1969, which is 53 years ago. This is a copy of the original document they use, and they then published their data with little hand-drawn histograms. It is actually quite cute to see. And they checked the patients for that's had a halothane, methoxyfluorine, cyclopropane, spinal, epidural, and then the intravenous group right to the right there. Now, what did they mean by intravenous group? Because at that stage, the only induction agents there were forbanthol and then the barbiturates, Briatol and pentothal. So they had no infusion pumps or TIVA techniques then. So that was most probably procedural sedation where just a single dose of something was given to have a quick procedure done. And that was considered to be IV and anesthesia in those days. Now, if we look at Look at that. On arrival in the anesthetic care unit, the intravenous group scored a score of 10, 55% of them, and then 8 to 9, 30, and then below 8, 15%. But after 1 hour, the 10s went down to 15%, the 8 to 9s went up to 33%, and the below 8s went up to 52%. So why they should actually be waking up. So why are they scoring worse after 1 hour? And they attributed that to it's either from a single shot of evanescent drugs or repeated boluses of a slow onset of action drug that was given. Therefore, like pethidine, we know pethidine takes 15 minutes to work. You use it for a gastroscopy. The gastroscopy is long done before the pethidine starts working. That could have been responsible for this. Very important from their study, aspects that still holding true today, and that's the recovery of patients only really gets worse after surgery extending 6 hours. Age is not a determining factor regarding post-op recovery. ASA status is not a recovery. When you get to the ASA4s, they take a little longer because of various reasons, and sex is also not a factor with regards to post-op recovery. This is just to show you that there are quite a number of these scoring systems available today. Now, the question can be asked, that was all in 1969. Does that still hold true today? And there's a very interesting article published by Philip Roland from Leuven in Belgium, saying that the number of patients receiving procedural sedation is getting more and more. That is common knowledge, we know that. But that places an additional burden on every recovery room or a post-sedation care unit, and the flow through that unit and the scientific management of patients become more and more and more important, because these patients come in, they have to be monitored appropriately, and they must get out. It's terrible to say it, but that is unfortunately how it works. Roland and his group took 231 patients that had GIT endoscopies. Then they had 2 observation periods. The first period was the recovery room staff just went about their business the way they were used to do it. And then they trained them, and with the second observation period, they've been trained in a recovery room scoring system, and they compared the two. And during the first observational period, the average stay in the post-sedation care unit was 59 minutes, and then after the staff had been trained in the scoring system, that went down to 47 minutes, and that was with identical doses and levels of procedural sedation and analgesia. So the decrease in the sedation unit stay was between 90 to 30%, 35% of different endoscopic procedures. So if you properly score them, you actually get these patients to move through the post-sedation care unit quicker. And this is just a graphic explanation of what they've done. You'll see to the right there, blue stop, blue stop, blue stop. That is good. That is what we expect. But then, look at that. For the first, 40 minutes, the patient's been properly monitored according to the discharge scoring system, actually did worse than the patients before. And that is most probably that the nursing staff in recovery, they assumed that procedural sedation had no or very little dangers. The patient had sedation only after all, and strict sedation care units protocols have not been applied, and they only realized that they all along had been discharging these patients from recovery when they were actually, if compared to a scoring system, they were not ready to be discharged. And that was published December 22. All the procedures, average control time 59 minutes after the application of the Aldrete score, 47 minutes. So apart from increasing the quality of care that the patient in recovery gets, you manage to get them passed through recovery much quicker. Something that I read that was interesting, the phases of recovery. Internationally, there's a phase 1, 2, and 3. Phase 1 is theatre and directly post-surgical. Phase 2 is a step down in a facility where they say the patient is readied for discharge. It's the first time that I heard that. It's actually quite a nice phrase. You ready the patient for discharge, and the late phase is later on. Just of interest sake. She also stated that using a standardized tool provides consistency of care, reduces errors, promotes efficient use of resources, meets Joint Commission requirements. Joint Commission in the States is a very high and powerful commission, and it meets the Aspen recommended standards. The use of the scoring tool should be taught as part of the orientation to the unit. Are there other factors that contribute to longer time spent in recovery? This study showed that patients with a history of stroke, a group of patients for upper GIT endoscopy, history of stroke almost 10 minutes longer. Patient with a hypertension almost 3 minutes shorter. Midazolam 3 milligram versus 2 milligram, 3 minutes longer. Propofan 6 ml had a longer recovery than propofol 7 to 12 ml, and that is most probably because they've used bigger doses of midazolam, so they could cut down on the propofan dose, but the wake-up time was extended by the midazolam. But there are other factors, and there are many. That was just a graph of what they found. Then, of course, a capnograph has to come into the equation, and it was investigated whether the role of the capnograph in prevention of adverse events in recovery actually plays a role. And from just over 1,000 patients without capnography monitoring for their sedation, they had 11.45 events per 100 procedures. Patients with capnography monitoring, 1,044, almost just over 1,000 patients, had only 5 events per 100. So it was clearly proven that by monitoring your patient intrasedation with a capnograph and avoiding the big danger, which is respiratory compromise, actually leads to far less respiratory events post-operatively. You all know this book. There's a copy, Appendix 13 of the modified Aldrete scoring system. Aldrete said color. ARC3 color was one of them. The modified Aldrete system, they took color out and they put the oximeter reading in there. We nowadays use the PADS system, and that is also to be found in the sedation guidelines. Now, just to end off with just to think logically for a while, what do we do to our sedation patients? First of all, we give them an anxiolytic and we depress their level of consciousness. And also together with that, we cause respiratory depression. We give them an opioid and we diminish or we reduce the CO2 sensitivity and response reaction, and we give them a sedative, which quite frankly, virtually always has cardiovascular effects on these patients. So the patient we're bringing into recovery has a depressed level of consciousness. They're most probably hypercapnic because we know from using an infrasedation nasal capnograph that CO2 reading doesn't mean anything because it's a loose-fitting mask. It entrains room air. It is merely there to show you that the patient is actually moving CO2. Okay, so your patients potentially can be hypercapnic, they can be hypoxic, they can have peripheral vasodilatation. Their temperature control can be a problem if it's been for a big plastic surgery procedure taking 3-4 hours. They can be hypertensive and they can have a tachycardia. That is the kind of patient that you now hand over to the nursing staff in recovery. So what should our recovery room talk to the nursing staff be? First of all, this is Mrs. So-and-so, no allergies, known with the following: ischemic heart disease, COPD, diabetes, whatever, had procedural sedation with midazolam, it's a sedative, with L-fentanyl, that's an opiate, that should alert your recovery room personnel, and some propofol. And then just a quick summary: patient was stable throughout the procedure. I struggled with the blood pressure, checking the blood pressure more regularly than what you normally would do. This is what I think is our responsibility, to inform with the recovery room staff about the patient that we are bringing to them. We've been there. So the bottom line is, I call it the post-sedation care unit. Whether that is the same dental chair where the child or the patient is just had the procedure, if you're waking the patient up there, that becomes your post-sedation care unit. There are a number of questions about that as well, but let's leave it at that. And the guidelines are available to follow to the benefit and the safety of all involved: the patient, the staff, and lastly us. The guidelines and protocols should be taught and implemented and documented. All these documents are in the guidelines. And what I always say, we as the clinicians, we can hand a patient over to the staff in recovery. Now they look after the patient. We can delegate our duty or our work, but we cannot delegate our responsibility. That patient stays your responsibility till the patient is ready for discharge. At the hospital where I work nowadays, you must actually physically sign the patients out of recovery. The sister comes to you, she says, listen, patient stable, there's all the post-op data, you happy for this patient to go to the ward, and you must sign it. The responsibility of post-sedation care still is with us. Thank you very much. Thank you.